A very good evening to all of you. Today is the 34th webinar of FSIBC, and we have chosen another important topic for today, that is genomic assays in breast cancer management. So I will like to invite Dr. Dinesh Singh. Before that, I would like to congratulate and extend my best wishes to my seniors, Dr. Dinesh, Dr. Arun, and Dr. Vaishali for their new venture. So, sir is Chairman, Department of Radiation Oncology at Andromeda Hospital, Sonipat. Over to you, sir.
Thank you, Dr. Prikshi. And I welcome all the esteemed faculty and all the attendees to this 34th event of our FSIBC. Today, the topic is quite important and relevant because now most of the patients are moving towards personalized care of breast cancer. And many times we are faced with a situation whether the patient should be receiving chemotherapy or not, and what are the biomarkers which help us in reaching to that conclusion. So oncotype DX is one of the very important thing, and we are having lectures and panel discussions to deliberate over this very important topic. To take it further. Thank you so much.
So we'll go ahead with our first session, genomic assays in node-negative breast cancer. So majority of the guidelines, actually, they recommend these multi-gene signatures. But let us have some more insights regarding the prognostic and predictive value and the evidence-based decision-making. So for that, I would like to invite Dr. Venkat Koella. He is Director, Medical Oncology at Shankara Institute, Tejpur. Dr. Venkat.
Good evening, colleagues. Thank you for the kind introduction.
If you can reshare it again, sir, we cannot.
Yeah, I'm switching the view.
Sir, you can click on that 3 button and the
Yeah, it's good.
Yes.
Thank you. It's so nice to see colleagues and seniors on platform. Thank you for bringing together all of us. And today I'm going to discuss about role of oncotype DX and other multi-gene assays in N0 status, early breast cancer, hormone positive and HER2 negative. While the rest of the country is in summer, here in Assam it is raining heavily, and our district is affected by floods, and so many animals are coming due to the flooding of their habitats. So let me continue with the topic. So I have no disclosures to declare. And this is an era of multi-gene assays, which have never been discussed as much as these times, particularly for predicting chemotherapy benefit. Because as the people are getting aware, the physicians are getting aware, now more and more usage of multi-gene assays are being done. So I am going to deal this topic in the following heads to give overview of what multi-gene assay is, and to focus on N0 status breast cancer with some discussion on clinical trials and evidence, and why clinical decisions are not very much appropriate in early breast cancer while selecting or not selecting for the patient for the chemotherapy. From the analysis of EBC-TCG meta-analysis, we do know that very few patients actually benefit from adjuvant chemotherapy, because in this analysis, only 1/3 of patients are N1 status, and the benefit that is shown is equal between chemo and endocrine therapy. And a very particular subset of patients only are benefited from chemotherapy. And when we see the statistics of newly diagnosed breast cancer patient in United States, which has one of the highest burdens of breast cancer across the globe, ER positive and HER2 negative breast cancers with N0 status account for nearly 1/2 of the newly diagnosed breast cancer cases each year. And we do know that chemotherapy, like comprising of anthracyclines and taxanes, is life-saving in some other patients, while it may cause severe side effects in some other patients. So the question is whether we can avoid chemotherapy by carefully selecting those women in which chemotherapy may not be useful. So is there any such predictive assay? So we do know chemotherapy has short-term as well as long-term side effects. Some of the short-term side effects including stomatitis, fatigue, chemotherapy-induced nausea, vomiting, GI side effects. Cytopenia sometimes can land in sepsis and neurocognitive dysfunction. And long-term side effects which may affect the quality of life as well, like affecting infertility, persisting severe peripheral neuropathy, persisting alopecia which may not recover after completion of chemotherapy, cardiac dysfunction, so on and so forth. Not only that, along with the patient receiving chemotherapy, it is a burden to caregiver, the family, and of course, it is a burden for the society, which is actually sponsoring the chemotherapy, like in the Western countries predominantly. So there are two types of biomarkers. We know that there are the prognostic biomarker and predictive biomarker. When we say it is prognostic biomarker, it informs on the clinical outcome independent of treatment received. Whether what is the chance of relapse, the aggressiveness of the tumor based upon the intrinsic nature of the tumor. The predictive therapy biomarker is it helps us in knowing the response to a specific type of treatment. For example, in presence of estrogen receptor for hormone therapy and HER2 positiveness for the targeted therapy, HER2 directed targeted therapy. So when we are making adjoint decisions, most often we have to depend on prognostic factors till we have these multi-gen assays, and only a few of these parameters are predictive significance. When we see the prognostic factors as such, which are available to us when a patient with breast cancer is being examined, we take into consideration age, the nodal status, tumor size, tumor grade, ER/PR HER2 status. So these are the most important information we are using till now. And with the presence of Oncotype DX and approval across most of the societies, it is helps in prognostication as well. And coming to predictive factors, which help in selecting or predicting the response to a specific therapy, the estrogen receptor, hormone receptor, that is HER2 receptor, as well as Oncotype DX. So Oncotype DX is a multi-gene assay which helps both in prognostication as well as in predicting the response of a patient for the benefit of chemotherapy. This is the topic of multi-gen assay has evolved because for the rest of the two conditions, for the hormone therapy and targeted therapy, we have predictive markers which can easily detected by simple immunohistochemistry that is available anywhere. But for the predictive benefit of chemotherapy, we required a specific investigation that help us in making a decision to say yes or no for chemotherapy. So of all the multi-gen assays which we are going to discuss, Oncotype DX helps in identifying the patients and defining the, not only identifying, but helps in defining the magnitude of chemotherapy benefit based upon the scope and support the treatment decisions by oncologists or the tumor boards. So what exactly is Oncotype DX? So in the trial NACBP 20, 250 genes were selected of all the breast cancer patients, and of these, 16 important cancer genes were taken into consideration, which are concerned with proliferation of the tumor, invasion of the stroma, as well as the pathways of the ER and HER2, and other survival pathways like GSTM1 CD68. And along with these, 5 reference genes have been selected and making it a 21 gene assay for giving a score that is predictive of benefit and risk score analysis. And when we say the score, so it ranges from 0 to 10, 10 to 30, and 30 to 100 as well. So the score can range anywhere between 0 to 100. So in which particular setting Oncotype DX is useful? So when a newly diagnosed early breast cancer, invasive breast cancer is detected, if it is HER2 positive or triple negative, effectively Oncotype DX will not be useful. They will go into those pathways. And it is useful when it is hormone positive and HER2 negative, and there is a N0 status or N1 micrometastatic status or N1 status. So in these three settings, early breast cancer, hormone positive and HER2 negative, Oncotype DX recurrence score is useful. So it is why I am discussing Oncotype DX is it is one particular multi-gene assay which has actually support of randomized controlled trials, both in terms of prognostication of disease and prediction of chemotherapy benefit, and also for the magnitude of the benefit. So when we see the prognosis of the prognostication of disease by Oncotype DX, the trials that are helpful in the N0 setting are NACPP B14, and there are two other trials that helps in prognostication, TransAttack and Plan B, but it included an node positive disease also, which my colleague Dr. Nilesh will discuss in the due course. And prediction of chemotherapy benefit is derived from these trials, NACPP B20, retrospective and prospective analysis of NACPP B20, and SWOG 8814. And the magnitude of chemotherapy benefit, particularly in a particular subset of intermediate benefit risk score, either TILREX and in node positive or responder. So these are the trials which support and add data to Oncotype DX and compare arm to arm, RCT. So this is a study of NACPP20, which is a prospective retrospective study using this 21 gene Oncotype DX. And when we say high score, it is greater than 31 in this study, but which is slightly different from the scoring in TILREX. NACPP20 effectively establishes the ability of Oncotype DX to predict chemotherapy benefit. And we can see here there are three sets of patients, that is low score 0 to 10, in which there is no chemotherapy benefit, and 11 to 25, which is the intermediate score, in which there is no chemotherapy benefit, and greater than 26 is called as a high score, in which there is a definite absolute chemotherapy benefit up to 26%. So this effectively established the Oncotype DX, and so it is approved after this study in majority of the societies as a recommendation to use this test in selecting the patients for adjuvant chemotherapy. And TILREX is a trial answering a particular question of whether chemotherapy is beneficial for women with a mid-range recurrence score of 11 to 25. So the scores are slightly different as we discussed. 0 to 10 is considered a low score, 11 to 25 is the intermediate score, and greater than 25 is considered a high score in TILREX trial design. And we can see here grade 2-3 tumors which are node-negative are included in this study. And the patients with intermediate score, that is 11 to 25, have been randomized by addition of chemotherapy to endocrine therapy versus endocrine therapy. And the primary endpoint of TILREX design is invasive disease-free survival. And we can see here the TILREX has met its endpoint, and it has shown that in this particular subset, particularly in postmenopausal patient, and as well as in the intention to treat population, the entire population, addition of chemotherapy to endocrine therapy will not help much when compared to endocrine therapy alone in the intermediate risk group as well. That is between the scores of 11 to 25. So TILREX N0 has clearly mentioned that chemotherapy will not be beneficial in the scores of 0 to 25 effectively, because it included both low risk as well as intermediate risk. Now coming to the subset analysis of the TILREX and these studies, we can see here if the woman is greater than 50 years and postmenopausal, a score up to 25, there is no role of chemotherapy, and only if the score is above 26 up to 100, there will be substantial chemotherapy benefit. And coming to two other subsets who are young breast cancer, that is less than 50 years, who are postmenopausal and N0, the benefit is still may be there in the intermediate scores, that is 16 to 20, there is 0.6% of benefit, which is very less. And when the recurrence score is 21 to 25, there can be 27.8% of CT benefit, which is still less when compared to those population who are being benefited by score more than 26. But these are the subsets which may be benefited from chemotherapy and which helps in the discussion. This is the magnitude of benefit we see in young patients. When we see the premenopausal patients in node positive status, the benefit of chemotherapy will be still higher, and which may seep out into the early low scores also, which will be elaborated by my colleague. Now, not only that, Oncotype DX and TILREX has showed the benefit in the randomized control trials, but also in the real-world data, including C registry of USA and CLATE registry of Israel and global clinical laboratory experience. So in all this data, we can see that the amount of patients, the number of patients that are being benefited by chemotherapy are less than 1/5 of the total population. That is less than 20% of all the patients analyzed are benefiting from chemotherapy. So what is the impact when we use these studies? So the studies which actually see this when we use such a real world data into the evidence, what will be the impact? They are called decision impact studies. And decision impact studies of TILEX have shown that they avoid the risk of over treatment and risk of under treatment. If we use this 21 gene assay, in other words, if we don't use this 21 gene assay and use only clinical parameters, there is 73% risk of over treatment. If we use only tumor grade, size, and nodal status. In the same way, there is a risk of under treatment in 9% of patients based upon the TILEX analysis, the type of patients that are included in the TILEX grade 2, grade 3 patients. So TILEX and RxPanda are the two trials adding a predominant and impressive body of evidence to this for using Oncotype DX in node negative and node positive patients respectively, because the number of patients analyzed is quite significant in TILEX. More than 85,000 patients node negative and 18,000 patients are node positive together. So after this data, particularly after 12 years of analysis, update of TILEX, both that is American bodies as well as the European bodies have approved 21 gene assay to be used to predict the adjuvant chemotherapy benefit. In USA, NCCN and St. Gallen, as well as ASCO, all the three bodies have approved Oncotype DX. And in Europe, NICE and ESMO both have approved to use 21 gene assays for the predicting of chemotherapy benefit. So coming to the conclusions of Oncotype DX breast recurrence score, it is the only assay to predict chemotherapy benefit as such. It is an independent predictor of chemotherapy benefit and patient outcomes. Most important thing is it helps in both reducing over treatment and under treatment. So when we see, we have already seen the trials. NSABP 20 helped in showing the benefit, that 26% absolute benefit of chemotherapy in those with greater than 26. So it also not only helping in excluding the patients from chemotherapy in those who might not have benefit, but also selecting chemotherapy who might have more risk of recurrence if chemotherapy is not given. So, so this is one of the important slide. If we use the clinical risk only as a parameter to select, so 73% of patients who actually are deemed as a clinically high risk and must have received chemotherapy, actually they might have over-treated because their scores are between 0 to 25. If we have done the testing and if the score is less than 25, we will avoid chemotherapy. But the clinical parameters will show it as 73%, approximately this amount of population as a high risk. In the same way, 43% of patients who are clinically low risk might have been undertreated if TILEX test or Oncotype DX is not done. So the conclusion is that tumor size, grade, and clinical risk category might not be predictive, which we are using till now. So this is the analysis in the TILEX study. We can see here, when the TILEX group risk is 0 to 10, there are still 22% of population which are actually genetically high risk based upon the score. That is, score is more than 26. And even in the intermediate risk, where we might have avoided chemotherapy based upon the clinical, based upon the risk analysis, the clinical risk, high risk is showing nearly 26%. So which these people might have unnecessarily treated with chemotherapy. One of the important update about TILEX is the long-term 12-year analysis, because we do know that hormone-positive breast cancers recur late. So whether this trial design is useful in predicting the late recurrences as well. And TILEX design includes a 20-year follow-up, and as of now we have 12-year follow-up and update at 22 ASCO. So distant recurrence is 7% at 12 years update, both in endocrine therapy and chemoendocrine therapy in the intermediate risk, which means even if we have added chemotherapy to the intermediate risk, so the risk of recurrence at 12 years is the same, effectively as same as giving endocrine therapy alone. And we have clearly seen that the invasive disease-free survival is definitely more when chemotherapy is given beyond score of 26. However, in premenopausal women and in women less than 50 years, the benefit may be seen in the intermediate score also, and so it involves individual decision making. So coming to the other multi-gene assays, which are prognostic only multi-gene assays, unlike Oncotype DX, which is actually predictive and prognostic. A few of the tests are endopredict. The problem with endopredict is there is no randomized control trial supporting endopredict, and there is a gross discordance between the recurrence scores of 21 gene assay and endopredict. And it is seen that nearly 47% of the intermediate and low risk population will be graded as high risk in endopredict. And highest level of evidence that the RCT is not present in endopredict, and it is not validated in premenopausal status. So all multi-gene assays are not same and they are not interchangeable. So we should be very careful while selecting the assay because they are very costly, and the decision making, we should consider those tests which have evidence adequately. And same way with the Prosigna, there is as many as double the patients are classified as high risk in Prosigna. So effectively double the patients will receive chemotherapy if you use Prosigna instead of Oncotype DX. So these are the data showing the discordance between Oncotype DX and Prosigna, and the discordance ranges anywhere between 40 to 50%, which is quite high. Again, this is Prosigna also doesn't have a RCT backup. And Mammoprint, the discordance rate is almost same as Prosigna, with twice the patients being categorized as high risk compared to Oncotype DX high risk. And coming to the tumor size, because it is a variable phenomena and the tumor size is subjected to the grossing as well as the pathologist's experience. And tumor size, it has shown that even in tumors which are less than 1 centimeter, their population with they are women with high risk score. So the tumor size is not a perfect parameter to take a decision. In the same way, it is shown that in Tildex study, there is no significant association between the risk score and the tumor size. So there are high risk patients even in very, very small tumors. So the conclusion is that tumor size is not predictive of chemotherapy benefit. And in same way with the tumor grading, it is also a subjective phenomena. And there will be at least 30% inter-observer variability in nuclear grading. So a grade 1 in one institute may be grade 2 in another institute, and it may actually lead to confusion in taking decisions. And it is also shown that in grade 1 tumors also 7% tumors have high recurrence score, which is quite surprising. 1 in 10 patients are in grade 1 tumor also have high recurrence score and might require chemotherapy. So tumor grade does not predict the recurrence score, and it has been shown not only in Tildex but across other multi-gene assay studies as well. So tumor grade does not predict chemotherapy benefit. And K67 again is very, very controversial and subjective variable. So many of the guidelines, many of the society has given up K67 as a predictive marker for chemotherapy. So although we see 70-80% K67, when it's reanalyzed, it will be very less. So it is very much a subjective phenomenon. And K67 is not predictive of adjuvant chemotherapy benefit when we, based upon these trials, which have analyzed postmenopausal women for chemotherapy, endocrine therapy, and OFS. And it was seen that the K67 and recurrence scores are not correlating. Nearly 45% of discordance has been noted between K67 and recurrence score result. And that is the reason why K67 is not being used. And age and menopausal status are also fixed variables, and they cannot be completely, we cannot use these status as decision-making effects. However, we have seen the importance of menopausal status in selecting patients for chemotherapy based upon the results of NSABP20 and Tildex. So this is how a Oncotype DX report is usually reported. So it will give a recurrence score result 13, which is intermediate risk, and it also gives the distant recurrence risk at 9 years and absolute chemotherapy benefit, how much will be given. So this is how the report looks like. So with this, I conclude my talk and thank you so much.
Great presentation, Dr. Venkat. So now we have insights about the role of Oncotype DX and other genomic assays in node-negative patients. However, we have now some studies, some papers coming with the role of these genomic assays in node-positive patients. So we'll listen to it with our next speaker, Dr. Nilesh Dhamne, who is Senior Consultant, Department of Medical Oncology at Kolhapur Cancer Center, Kolhapur. Over to you, Dr. Nilesh.
I'd like to thank the organizing team, Converse, of this wonderful venture. Probably the today's is the 34th meeting, and I will be talking on the role of genomic acid in node-positive breast cancers, especially early breast cancer. So Dr. Pradeep has given a very insightful information about the need of prognostic and predictive markers for early breast cancer, the role of adjuvant chemotherapy in this setting with endocrine therapy. Node negative part is pretty much cover about the Taylor trial. I will be talking about the role of this genomic assay in node positive early breast cancer, mainly RX Ponder trial. Is my screen visible?
Not yet.
No.
Now?
Yeah, now it's
So I would like to give background. Actually, Dr. Pradeep has covered pretty much the background, the need for predictive and prognostic marker. About the SWOG, that is Southwest Oncology Group 8814 trial, the basis of this prognostic predictive marker and 21 gene assay that has been partly covered. I would pretty much like to jump to RX Ponder and the conclusion and the take-home message and how we interpret the result of this node positive cancer. So this is the SWOG 8814 trial, which talk about the adjuvant chemo and timing of endocrine therapy, that is tamoxifen in postmenopausal women which are endocrine responsive, however, node positive breast cancer, a phase 3 open level RCT. So there were 3 randomization. So they tried the sequential as well as the concurrent administration of endocrine therapy to chemotherapy versus there is no chemotherapy, only endocrine therapy arm. So 381 patient assigned to TAM alone, 590 CF chemo followed by tamoxifen and 587 concurrent, that is a CF along with the tamoxifen. So after that, almost more than 90% patient received the treatment. Interpretation is that chemotherapy with CAF plus tamoxifen given sequentially is more effective adjuvant chemotherapy for postmenopausal patient with the endocrine responsive node positive breast cancer than TAM. However, it may be possible to identify some subgroups that do not benefit from anthracite-based chemotherapy despite positive node. This was more of a retrospective analysis for predictive benefit, and there was a warrant for a prospective study. So this is the RX Ponder prospective study, which does mean a clinical trial treatment for positive node endocrine responsive breast cancer. Predictive chemotherapy benefit in node positive breast cancer with a 21 gene test. The Oncotype DX breast recurrence score test. So as we know, vast majority of early breast cancer may not benefit from adjuvant chemo. This is the early breast cancer collaborative group meta-analysis of randomized study in trial with the anthracycline-based chemo versus no. If you follow the 10-year course, less than 10% have absolute benefit of chemotherapy. But this is a generalized statement and there was no differentiator about the all categorized patient. It included node negative as well as node positive. So 18% were node negative and 82% were node positive. Out of that node positive, there were 1, 2 versus 3 nodes positive also. However, the absolute benefit of all together was less than 10%. So we need to find a subgroup patient who really need and may benefit from adjuvant chemo. So 21G test result was predictive chemo benefit in node positive. So recurrence score 0 to 17, 18 to 30 and more than 30. On the pretty much left side of the slide, if you see the breast cancer specific survival on the y-axis compared to the number of year on x-axis, there was no any significant benefit of addition of chemo for a score less than 18. Between 18 to 30, there are also no significant benefit observed. However, when it goes to about 30, 31 to 100, there was a 19% absolute chemotherapy benefit for a chemotherapy added to endocrine therapy in a patient of early breast cancer who are hormonal positive, however, node positive as well. So recurrence score does predict chemotherapy benefit in first 5 years. The interpretation, the p-value is 0.029. So less than 0.05. So significant p-value. The SWOG 8814 was the basis of this RX Ponder study because SWOG 8814 showed the if it is score around 25, less than 25 versus more than 25, the benefit of chemotherapy goes substantial. RX Ponder was conducted to further refine chemo benefit estimate in hormonal positive, HER2 negative and early breast cancer patient. So the women were more than 18, node positive 1 to 3, hormonal positive, HER2 negative. The stratification factor were score 0 to 13 versus 14 to 25, menopausal status pre versus post, the type of nodal surgery, axial lymph node versus sentinel lymph node biopsy. So oncotype D is given the recurrence score 0 to 25 and 26 to 100. There was a further stratification for 25 versus 0 to 13 and 14 to 25. So for the women, 0 to 25 score randomized into ET alone versus chemo followed by ET. And there's a for 26 to 100 chemotherapy followed by endo is recommended. Primary objective of the study was determine the effect of chemotherapy, if any, in invasive DFS in women with a lymph node positive disease and a score between 0 to 25 with the adjustment for menopausal status. Now the patient characteristic by treatment arm, age was a fairly managed between the two arms, that is around 57 was a median age. Menopausal 1:2 almost, pre-menopausal 33 versus post-menopausal 66. Positive node 165 constitute the bulk of the patient, 2 nodes 25 and 3 were only 9%. 0.3 has no reported. Nodal dissection, axial lymph node with or without sentinel 62 and sentinel 37. So both arms were fairly managed, fairly balanced, and across the different characters is menopausal, nodal 1 to 3, nodal dissection type, recurrence score 0 to 3 versus 14 to 25, grading grade 1 to 3, tumor size T1, T2, T3, and a clinical risk high risk versus low. So the both arms were fairly balanced. N1 postmenopausal women with a recurrence score 0 to 25 showed no chemotherapy benefit in updated analysis with 6.1 years median follow-up. So this is an invasive disease-free survival for a postmenopausal recurrence score 0 to 25. No statistical significant for invasive disease-free. When it comes to distance relapse-free survival, there was no any statistical significant difference found. Again, this is a time from randomization assignment to days for first invasive recurrence, distance, or death from breast cancer. They couldn't find any statistically significant for distance recurrence-free interval at the end of 5 years with the addition of chemo in N1 postmenopausal with a score 0 to 25. Any further subgroup, however, no any subgroup showed a benefit from chemo, whether it's age, grade, size, clinical risk, nodes, scores, results, or histological type. So the final interim final analysis, there was no any benefit of chemo to endocrine in N1 postmenopausal with a score less than 25. Coming back to premenopausal, N1 premenopausal recurrence score result 0 to 25 women showed a benefit from chemo in updated analysis with a 6.1 year median follow-up. So invasive disease-free versus distance relapse-free survival, premenopausal 0 to 25. 5-year invasive disease was absolute difference 4.9 versus, and distance relapse was a 2.5%. This is again N1 premenopausal. So distance recurrence free survival for 0 to 13 was 2.3, for 14 to 25 2.8, and in combined, it was 2.4. So for a distance relapse-free survival for endocrine alone was a 6.1, and with the chemo addition, it reduced to 3.7. And nearly all subgroups of node positive premenopausal women with a recurrent 0 to derive a benefit from chemotherapy. So this is again this pictorial 0 to 25, differentiate 0 to 30 and 14 to 25. So the absolute magnitude of benefit for invasive disease free was a 3.9 for a score 0 to 30, and for 14 to 25 it is 5.8. So this is the exploratory analysis model fire invasive disease events in a premenopausal. So endocrine versus a chemo arm. Post hoc analysis in premenopausal women with node micromets versus macromets, that is PN1 MI versus PN1 benefit, though the limited number of events for N206 versus 1403. So the number of events, however, in invasive disease-free survival for addition of chemo was 89 versus 97, and in N1 88 versus 93. So prior to protocol amendment, excluding PN1MI, that is a micromets, 27.9 eligible premenopausal had a micromets only, and 6% unknown. Is there any effect of OFS on the treatment? So OFS treatment rate is low and they remain consistent in both arms. Landmark 2-year invasive disease by ovarian function in patient assigned to ET. So no difference between the patient who received ET plus OFS or only ET alone in first 24 months. Though higher in endocrine therapy, the rate of regular menses, the rate of regular decrease in both arms. So numerically improved invasive disease-free survival in premenopausal women, no longer having regular menses in first 24 months in both arms. So whether it's chemo or chemo plus endo. So to conclude, the majority of N1 postmenopausal can now be spared from chemo with a recurrence score 0 to 25 independent of clinical pathological parameter. In an updated analysis with longer follow-up postmenopausal women with a score 0 to 25 continue not to benefit from adjuvant chemo. N1 premenopausal patient with a recurrence 0 to have a 2.4% benefit from chemo based on 5-year distant recurrence-free interval. Our responder was not powered for subgroup differences, and data interpretation can be challenging given that confounder can change over time. Our responder results add to finding of SWOG 8814, the study that established 21 gene assay as a predictor of chemo benefit in N1 postmenopausal patient. So majority of hormonal positive HER2 patient who are early breast cancer can be spared from chemo when decisions are guided with the 21 gene. So postmenopausal, that is more than 50 years, another criteria, node negative, 0 to 25, or even N1, 0 to 25, no chemotherapy. However, the score above 25 to 100, substantial benefit irrespective of nodal status. However, when it comes to premenopausal, 0 to 30, node negative, no chemo benefit, 15 and above, 1.6 chemo, and 16 to 20, 21 to 25, the increases to 6.5. And more than 25, there is a substantial chemo benefit. Node positive, premenopausal score as low as 0 to 30, 2.3 chemo benefit. For 14 to 25, increased to 2.8, and for a score more than 25, substantial. So to conclude, all patients who has a score more than 25 will have substantial chemo benefit. For a postmenopausal 0 to 25, chemo can be spared. Even for premenopausal 0 to 30, node negative chemo can be spared. The rest all, there is a chemo benefit. This is the chemo benefit as per the different registries. Now to go how to interpret and how the sample report of this oncotype DX comes. So for postmenopausal, there will be classification. This is on the left side, the score result. It will say the recurrence or mortality at 5 years with endocrine therapy alone, and the absolute chemotherapy benefit for a recurrence score more than what is. So for this patient, it was a 30. So for a proof 26 to 100. They will say for N1 postmenopausal, for this score, guideline recommend the chemotherapy because with endocrine therapy alone at 5 years, there is a recurrence as high as 17%. So when we interpret this oncotype in N1 positive patient, postmenopausal, there are two probabilities, 0 to 25, low risk, no chemo benefit, 26 to 100, high risk. When it comes to premenopausal, we will get categorizing to three different report, 0 to 13, 14 to 25, and 26 to 100. So this particular patient had a score of 30. If we give endocrine therapy alone for a high score, there is a more than 12% risk recurrence at 5 years. And there is a substantial benefit of chemo and to be added. And why? For 0 to 30, it's a 2.3 absolute benefit, 14 to 25, 2.7, and above score, there is a substantial and chemo to be offered. In this particular case, for a premenopausal, node positive, oncotype DX ideally only for prognostication because chemotherapy benefit is right from 0 recurrence score. So for premenopausal node, almost we are offering chemo. However, this test can help us prognostication how much will be the benefit because for score less than 25, in that also 0 to 13, 14 to 25, we get a different chemotherapy magnitude benefit. Thank you.
Nice presentation, Dr. Nilesh. So with all this information, the ground is all set. Now we will, please, can you stop sharing? Yeah. So the delegates who have any questions, please put in the QA box. And now we'll move ahead to our next presentation to see the Indian experience. For that, I would like to invite Dr. Sanjit Agarwal, who is Senior Consultant in Department of Breast Oncosurgery at TMC, Kolkata.
Good evening. Can you hear me?
Yeah.
Thank you all for inviting me for this presentation. And I really, the presentation from the ex-speakers were very helpful to setting up the scene for me to present about Indian data and how we decide upon chemotherapy in this particular subgroup of the patient. Thank you, Dr. Rajiv, Dr. Rajiv and team for giving me the opportunity to present. So give me 1 second. Let me share my screen. Can you see my screen now?
Yes.
Yeah.
Okay. Thank you very much. So genomic assay in early breast cancer. What is the Indian experience? Do we have enough data for oncotype DX or any genomic assay test in Indian setting? And I will share our institutional data. It's a small data, but it will give you a lot of insight about thinking of these testing in your OPD or in your decision making. So as we know that ER positive early breast cancer, decision on adjuvant systemic therapy is based upon multiple factors. One is the clinical risk estimation and second is genomic assay estimation. So generally there are two groups. One will receive only endocrine therapy and one will receive endocrine plus chemotherapy as a systemic treatment. And key decision factor is that how much benefit you are getting by additional chemotherapy, because if the chemotherapy is toxic too, chemotherapy has an additional cost too, and chemotherapy has long-term, both the short-term and long-term side effect, which affect patient quality of life in a very effective way, in a very impactful way. So coming to the how we make decision, as I said, clinical risk stratification is by we see multiple factors, just like age, grade, nodal status, generally N0 and N1 where we think to not to give chemotherapy, in N2 and N3 generally we give chemotherapy, tumor size, Ki67. And if you want to include all of this and want to calculate a objective score, we have available objective score from the UK group. This is known as NHS predictive score, where you will fill all the data and it will give you a predictive score for the chemo benefit. Similarly, for the genomic risk stratification, we have multiple tests available. I have named some: Oncotype DX, Mama Printing, IndoPredict, and Prosigna. But the real challenge in the Indian setting is this: the cost. Cost of the genomic assay, we all know, we say it's unaffordable to majority of our patients, and still we base our decision based on the clinical risk stratification in majority of the patient in our practice, at least in our setup. So how to super select the patient in this clinical risk stratification group itself, where the genomic test will be most helpful in decision making of the chemotherapy. So that's the purpose of our institutional data analysis. So clinical risk score, people who don't use, it's by NHS Predict, where you can put all these data. So it's an online predict tool where you will put age of the diagnosis, patient is pre-menopausal or post-menopausal, ER status, HER2 status, Ki67, tumor size, tumor grade, how it is detected, generally in India by symptomatic, and number of the positive node. And it generally give you a graph like this, and where you can see that what's the chemotherapy benefit in 5-year or 10-year, and you can see that what's the additional benefit of adding chemotherapy by using NHS Predict score, by putting all the clinical risk factor what we consider in our day-to-day practice for the chemotherapy decision. So if I compare two different, one is clinical risk score, that's known as NHS Predict score, and second is, as said by our ex-speaker, recurrence score. It both define the whole group in 3 groups. One is low risk, second is intermediate risk, and third is high risk. So low risk, as in the recurrence score, 0 to 10, 11 to 25, and higher than 26 is the high risk. Similarly, in NHS Predict score, we say if it is less than 3% predicted survival benefit, the patient is considered as low risk. Intermediate risk is 3 to 5% survival benefit in 5 to 10 years. And in the high risk, when the benefit of the benefit score is more than 5% survival benefit in next 5 years. So we predict as per the NHS Predict, and our study, our analysis main aim was to correlate the NHS Predict with the RS and see how clinical risk score is matching with the recurrence score. So before going to our analysis, we analyze that how many patients in our setting are eligible for Oncotype DX. So what we have done, we have collected the data from 2021 to 2022. So we treated around 1900 patients with the curative intent, out of which ER positive, HER2 negative, and has undergone upfront surgery were 480. And when we have took out the how many patients were eligible for Oncotype DX testing in our setting, it was 380 patients out of 1900 patients. So in our data, it's around 2-year data. 20% of the patients were candidate for Oncotype DX for the decision making for chemotherapy. And if we extrapolate this data, approximately 35,000 breast cancer patients in India. So I'm not giving you the CI confidence interval, but around between 30 to 35,000 of the breast cancer patients will be eligible for the genomic assay testing for decision making of chemotherapy, even in India, and it's a huge number to think of. So coming to our data, we have done Oncotype DX testing in around 73 patients in last 5 years. And out of which pre-menopausal node negative were around 12%, post-menopausal node negative were 33%, and post-menopausal node positive were around 55%. We have done Oncotype DX score in all of these 73 patients. And what we found that if we use Oncotype DX score in this group in our cohort, only 26% of the patient had chemotherapy as per Oncotype DX test result. But in retrospect, when we calculated NHS Predict score in same 73% by putting these all information in online Predict score for clinical risk prediction, the clinical risk prediction was high in around 71% of the patient. So if we had used this NHS Predict score in the same group of the patient, we would have given chemotherapy in 71% of the patient. So overall, seeing the 73 patient data itself is saying that if you are using clinical predict score probably you are giving chemotherapy in many patients, which can be changed by the Oncotype DX score result. Giving you more insight about this data, so we have tried to plot the scatter plot diagram. So this side is the x-axis is Oncotype DX, and y-axis is the NHS predict score. Both are quantitative data, and we plotted the scatter plot diagram for this 73 patient. There was no correlation between the two score, and the Pearson correlation coefficient was 0.01, and p-value was not significant. Let's see how, if we categorize the NHS predict result and Oncotype DX result in this 73 patient, what you will see. So you can see here Oncotype DX was low in 53 patient and high in 20 patient. When we have created 2x2 table, the NHS predict was low, the clinical risk score was low, indicating not to give chemotherapy in 21 patient. But Oncotype DX had changed in this group also, that out of 21, 5 patients had result with the Oncotype DX high score. So in overall 24% of the patient, it had changed the decision from no chemotherapy to chemotherapy in our cohort. Second is the NHS predict high score. So if you're using clinical predict score, the 71% of the patient is coming as low in Oncotype DX. So clinical predict score high and Oncotype DX was low in 71% of the patient. So decision-making change was in both direction. It doesn't mean that clinical risk prediction is low, then Oncotype DX will 100% come as low. So even in the low score, we found that in some patient, it was high score in the Oncotype DX. And in the high score, in around 71% of the patient, it was low in Oncotype DX. So 2 out of 3 patients. So overall, if I see how many patients we have changed the decision as per the Oncotype DX, it's around 58% of the patient. So if you are using clinical predictive score, and if you are using genomic assay, probably genomic assay will change the decision making in more than half of the patient as per our data. So NHS predict categorization was 71% as per our data. Do we have some Indian data of NHS predict categorization? Yes, there is a study where they compared the NHS predict score of India, Europe, and USA. And it was found that if you're using clinical risk score in this study, the 65% of the Indian breast cancer patient in ER positive HER2 negative group were high risk because of younger age, more grade 3, and more N1 in our age group. How the correlation, this is the UK data, this is not Indian data, but the UK data from where this 9% came, which was presented by the access speaker. So this is the study. They tried to correlate between the NHS and the Oncotype DX. And what they found that the NHS predict score is correlating well with the Oncotype DX when NHS predict is low. That's low risk predict. But because the predict is very high in our group, probably low risk predict will also not correlate as per our data with Oncotype DX in Indian breast cancer patient. And in intermediate to high risk NHS predict, it was not correlated as per the UK data. So NHS predict in the UK data or in the Western data is correlating somehow with the Oncotype DX when the clinical risk score is low. Although our data is only 73 patient, but we are seeing even in the low risk predictive score, it's not correlating with the Oncotype DX decision making. So coming to the, if we extrapolate this data to the India level, if I extrapolate this data to the Indian breast cancer patient of around 2 lakh of patient, 35,000 eligible for Oncotype DX. If you use Oncotype DX, 26% will receive chemotherapy, so 9,100. But if you use NHS predict or clinical risk prediction, 71% will receive chemotherapy as per the decision making based on the clinical risk prediction. So approximately the around 16,000 chemotherapy, probably with the no apparent benefit we are looking if we are not using the assay in all patients. But unfortunately, it's not possible due to high cost, and we need to think how to select the patient in this group. Sometimes we base our decision based on age, KI67, grade, nodal status, and tumor size. So we try to look upon the individual factor association with the oncotype DX in 73 patients. You can see that Ki67 in the continuous data analysis, both were quantitative data. It was correlating with the oncotype DX, but I will come in the next slide how it has impacted the chemotherapy decision making. And the age was also not correlating with the oncotype DX. And this is the Ki67 data. So you can see here when Ki67 was low, oncotype DX was high in only 1 out of 20 patients. But when Ki67 was high, oncotype DX was low in 64% of the patient. So in the decision making, when the Ki67 is high, and if you are basing your decision based on the Ki67, probably you are over treating with the chemotherapy in majority of the ER positive, HER2 negative breast cancer patient. Similarly, for the grade, as the ex-speaker said, grade 1 and grade 2, don't feel that all grade 1 and grade 2 will not need chemotherapy in this group of the patient, because 17% of the patient were upstage to chemotherapy by oncotype DX, 16% in the grade 2, and in the grade 3, 48% were downstage to no chemotherapy by using oncotype DX. Similarly, for the tumor size, it's not predictive at all. So in T1, you have seen that 3 patients had chemotherapy as per oncotype DX. In T2, 30%, and T3, no one, we have tested only 3 patients in T3, the oncotype DX, and all came as low score. This is the oncotype DX and nodal status. You can see in the node negative premenopausal patient, where all had NHS predict low, and we have tested them with the oncotype DX for the decision making, and 7 out of 9 came as high score with the oncotype DX. In the node negative postmenopausal, 71% were low with the oncotype DX, 31% were high, and the majority benefit in the node positive postmenopausal, because even in the postmenopausal 55 year, we say that we should give chemotherapy as per the clinical risk score. But if you use oncotype DX specifically in this group of the patient, it has changed the decision to no chemotherapy in 85% of the patient. So this is the Indian data. So this was a survey from the medical oncologist all around India. And the survey result was 71% felt that oncotype DX should be used for the decision making as per the TAILOR-X and RxPonder trial result, but 94% felt that it's expensive to use. So we are not using it in a routinely because patient can't afford. Let's look upon the cost of the chemotherapy. What is the cost of the chemotherapy and what is the cost of the oncotype DX? So if you see the oncotype DX test cost is around 3,20,000 rupees at present. It may change. It's old data. And chemotherapy in our setup, if I give 8 cycles of chemotherapy, the total cost of the chemotherapy is around 1,40,000 rupees. So if you see direct cost to cost comparison, probably oncotype DX, you feel that it's costly, but we need to think about indirect cost of the chemotherapy also, because indirect financial burden is there for supportive treatment. Patient need to travel 8 times to your hospital for the chemotherapy. Chemotherapy has some hospital admission due to the side effects. As per the data, it's around 5%. 150 days of the patient who will receive chemotherapy, which could be changed by the oncotype DX, is less productive for the patient. The patient need to go for the infertility treatment, ICU admission, and in unfortunate circumstances, we have seen that chemotoxicity related death too. So coming to the cost, we have tried to analyze the cost of the 100 patient. If we are giving 100 patient chemotherapy and 100 patient oncotype DX, the cost of the chemotherapy is around $1,500 US. But if you use transport, chemotoxicity cost, salary burden, some patient don't go to job, can't do their job during chemotherapy, long-term side effect and ICU admission, ultimately the cost is coming equal to the oncotype DX testing. So chemotherapy, what is in our mind is the direct cost, but we need to think for the indirect cost as a group of the patient. If you see one patient coming as positive for oncotype DX, we feel that it may not be useful, it's very costly. But if you feel as a group of the patient of 100 patient, probably if you're doing oncotype DX in selected patient, the cost will be almost equal for both the group of the patient, and reducing the chemotherapy toxicity in a majority of the patient by using oncotype DX testing or any genomic testing. So as I said, around 16,000 extra chemo impact on the healthcare and public system is also there, because you can reduce these chemotherapy by using genomic assay. The daycare bed will be available more, waiting list will be less, public and private transport with burden will be less, chemotherapy related side effect you can reduce, chemotherapy toxicity, emergency admission, and many more. So we really need to think about long-term and short-term impact of the chemotherapy on the healthcare, on the patient, and the indirect cost of the chemotherapy too. So what I see, the barrier to the genomic score testing is a one-time cost. Yes, patient has to pay one-time cost. It's not universally covered by insurance, both the private insurance and the public insurance. And turnaround time was a issue before, but now we are seeing the result available in the 2 week. What I say that you need to see for the chemotherapy side effect and the cost, think for the both direct and indirect cost. So this is the algorithm. If I have to propose the algorithm where you can super select the patient for oncotype DX, if the patient, we know that we need to super select the patient because the affordability, patient has to pay for oncotype DX in majority of the case. So early breast cancer, ER positive, HER2 negative, premenopausal node negative, and postmenopausal both N0 and N1 are eligible for oncotype DX. You can use NHS predictive score if it is less than 5%. No chemo in the post-menopausal node negative. Here the correlation is little bit better with NHS predict, but in the pre-menopausal, even if the NHS predict is less than 5%, be careful, or 3 to 5%, be careful to say that she will not need chemotherapy, because the oncotype DX testing can change the decision making. As per the data, our data 24%, but the universal worldwide data is around 10 to 20% of the patient. In NHS predict more than 5% in the same group, the genomic assay will change the decision making towards no chemotherapy in 4 out of the 5 patients. So it's a very useful to use in this group. And if you're using in this group, probably if you are thinking for a group, it will be more beneficial to do genomic assay if the patient can afford. And we need to convince the policymaker and the insurance company to start giving insurance or start covering the genomic testing too, because ultimately they're covering chemotherapy costs too. To conclude, what I will say that ER positive, HER2 negative breast cancer, chemo is beneficial in a very small fraction of the patient. NHS high risk has high discordance. So when you are saying clinically high risk, and if you are giving chemotherapy, if you're using genomic assay testing, probability of avoiding chemotherapy is 4 out of 5 patients as per the worldwide data and our data. It's a bidirectional change. In a premenopausal node negative clinical low risk score, also you will change the decision in majority of the patient by using oncotype DX or any genomic assay testing. Chemotherapy has both direct and indirect cost. Don't see direct cost. There is an indirect cost also. If you are thinking for a group of the patient, and there is a burden on the healthcare system by giving these additional chemotherapy with a lot of side effect and both short and long-term side effects. Genomic scoring is suitable for our patient. We have done in 73%, and we are thinking to start a multicentric data pulling and do a publication to see how NHS predict and the oncotype DX is related. And we need to have a consensus guideline for Indian breast cancer patient by all stakeholders in this group of the patient, where to use, whom to use, and how to use this testing. Thank you very much.
Thank you, Dr. Sanjit. That was some real-time data. Now we'll move ahead to our last session, which will be a panel discussion. To moderate the panel, I will now like to invite Dr. Vaishali Zamre. Ma'am is Director, Breast Cancer Surgery at Andromeda Hospital, Sonipat. Dr. Chirag Jain, Consultant, Surgical Oncology at Max Hospital. So we have our speakers with us, Dr. Venkat and Dr. Nilesh, who will be the panelists. Dr. Mrinalini, she is Associate Professor at KGMU, Department of Radiation Oncology. Dr. Aditi Chaturvedi, she is Senior Consultant, Surgical Oncology at Max Saket. Dr. Akhil Santosh, he is Consultant, Medical Oncology at MVR Cancer Institute, Calicut. Over to you, ma'am, and Dr. Chirag.
Thank you, Dr. Prekshi. I think Dr. Sanjit Agarwal, sir, is also there for the panel discussion. Yes,
I think
yes.
Dr. Nilesh Damne has just messaged that he has to leave for an emergency. So let me start the panel discussion. Thank you indeed. Although we are running a little late behind our schedule, but yes, since most of the things that were there in the panel discussion have been very nicely covered by the speakers. And I just hope that with this panel, we would be able, at the end of this panel discussion, we would be having answers to most of our questions on Oncotype DX and risk assessment scores in ER/PR positive, HER2 negative breast cancer. So welcome to all the panelists and the attendees. Let me start with the first case. Can you please share the screen, Mr. Nilesh? Sorry, Nirav.
Here.
Yeah. So the first slide. Moving on to the case one. So this is a 38-year-old premenopausal lady who has a breast tumor size of around 2.5 centimeters, which is an infiltrating ductal carcinoma grade 2. It is again ER/PR positive and HER2 negative with a Ki-67 index of 20%. One sec.
Previous slide.
Yeah, where a sentinel node was negative. So she is basically PT2 sentinel node negative. So my first question, Dr. Venkat, next please. So what are the options for the adjuvant systemic treatment? Dr. Venkat, would you go for chemo followed by endocrine or ET alone, AFS plus AI, or any other thing that you would like to offer?
Yeah, because it's N0 status, that is sentinel node negative. My concern here will be that in most of the trials we have seen till now, the multigen assays, the sentinel node aspect is not discussed. It is a complete axillary dissection, to my knowledge. So whether to consider the sentinel node 0 as N0, if yes, then the option should be to do multigen assay in this.
Right. So I think a sentinel node negative, we would still consider as a node negative patient only. Going by that, so you would offer multi-gene assay, this recurrence score testing for this patient.
Yeah.
Yeah. And any other thoughts, Dr. Akhil?
I would go for the same. I would go for a multi-gene assay in this case. Yeah, and decide based on the scoring.
Surgeons, Dr. Aditi is here.
I
Dr.
think
Aditi,
a multi-gene assay, if the patient, like of course after discussion, if it's financially possible, if it's a viable option, yes, multi-gene assay. Otherwise, in a premenopausal, if without multi-gene assay, I think I would err towards the side of chemo followed by endocrine.
So next slide, please. So if this patient is unwilling for chemotherapy, so we would say that we have arrived at a consensus that this patient is eligible for a risk assessment score, right? So next. So what test would you offer, Dr. Venkat, keeping in mind that we have various platforms to test? What test would be your first test of choice?
So as of now, if we want to use the best test possible, it's Oncotype DX without any doubt, due to the data that is available.
Right. And does tumor grade predict the recurrence score result or impact your advice, or it doesn't change anything for you? The grade of the tumor.
Grade, as you have seen that even in grade 1, there can be high risk status. So grade will not correlate with the recurrence score in many of the aspects. So it will not help us as such.
Dr. Akhil?
Yeah, as Dr. Venkatas explicitly said that all the factors like grade, size, node, and Ki-67, they do not have any correlation with the outcomes, and you should base your decision only on the genomic risk score. And even it's the same with the NSS predict also. So they, especially in high scores, there can be great discrepancy between the oncotype and the predict. So you should obviously base your results on the final scoring.
So it neither predicts the recurrence score result, nor does it predict the chemotherapy benefit, as I understand, right?
Yes.
And what about Ki-67, Dr. Mrinalini, ma'am? Do you consider any cutoff for a Ki-67 score to whether offer the patient an Oncotype DX test, or you prognosticate based on Ki-67 index?
I guess till today, I just set it at a 13.5% or 15% probably, not more than that. But as one of the speaker rightly said, they showed that there is no right correlation with the this score MIP index KI67 with the oncotype DS. So probably as patient doesn't want to take chemotherapy, maybe we go ahead with that. I mean, yes, we can go ahead.
So, Dr. Venkat, do you consider any cutoff for KI67? If yes, what is your cutoff for KI67 to decide on your further treatment of the patient?
All the variables available which we see in a pathology report, be it in biopsy or post-operative specimen, the highly variable parameter is Ki67. It is highly variable within the same institute between two different pathologists. So also we have seen that in the tail-dex and other studies which they have analyzed, there is 45% discordance between the clinically high risk based upon Ki67 and oncotype DX. So definitely not based upon cases.
That was when the oncotype DX was done by automated method, not by the manual hotspot thing. So it probably has a little better correlation. But as Dr. Venkat rightly said, that there was a 45% discordance. Yes, correct.
So just to put in context, any experience with any other platform other than oncotype DX, Dr. Akhil?
I myself have used only oncotype DX, but I have seen a few of the consultants in my institute. They have used the CAN assist scoring. So, but that is completely a different game altogether. It basically does an IHC based testing, and the cutoffs are also different. But the literature that I've reviewed so far, they have the CAN assist, the data they have actually retrospectively correlated with the oncotype DX and the Taylor X trials, and they have corroborated well. So plus the cost is also, I think it's exactly half of what the oncotype DX offers. I mean, and so for patients who have an issue with the cost, plus the turnaround time is also less compared to the oncotype DX because it is an IHC based testing.
Dr. Sanjeev sir, do you have any experience with any other platform other than oncotype DX?
We have very limited experience with the mama print, so we don't do CAN assist in general because we feel that the level 1 evidence is not available for CAN assist till now. We don't have any randomized control trial for the decision making for CAN assist. We have used mama print, but it's in very few patients. Our experience is also very limited to oncotype DX testing.
Dr. Aditi?
So I've used EndoPredict for a few patients and CAN assist also for a few patients. But again, like Dr. Sanjeev said, because we don't have level 1 data for CAN assist, it's only after thorough discussion that although our data is less, but yes, cost is it's not half. It's actually, it's almost like 1/3 or 1/4 actually of the oncotype DX. So the cost is significantly different.
Next slide, please. Next slide, Mr. Neerav. So this patient actually underwent oncotype DX scoring. The recurrence score was 20. Dr. Aditi, your comments?
So in a premenopausal with an intermediate, that 16 to 25, we really get stuck actually. We tend to err towards, chemotherapy. Then actually with a 20, you would have a risk-based discussion with the patient and the family. But at the 17 to 25 risk in this subgroup premenopausal, I think if the patient is willing to accept chemotherapy, but I think you mentioned that the patient was very keen not to get chemotherapy, then it's actually a patient-based discussion rather than a caregiver, clinician-led discussion, decision at that time.
So, Dr. Venkat, what would be your call on this?
Yeah, so in a premenopausal woman, we have seen that there is a benefit of chemotherapy, but not as much as in high risk. So we need to discuss, particularly in the gray areas, like in so many gray areas of oncology, we need to document whatever the discussion, because we are using a costly test and there is a chance of recurrence if you don't use, and there is a chance of side effects if you use chemotherapy, just like in. So we need to clearly discuss, document, and then go ahead. Even then, the women who doesn't want to take a minute amount of risk may still go with the chemotherapy, and who doesn't want the side effects may still go ahead with the close follow-up and not the chemotherapy. It will become an individualized discussion.
Right. So is this an area where, you get confused because of oncotype DX having categorized patients into low, intermediate, and high, or it guides you to, maybe do some other test which would help you to better define the risk of the patient in case the patient is very keen on not getting the chemotherapy? Any platform that would help you, or you are happy just with this result and then counseling the patient? Dr. Venkat.
Yeah. So I am not aware of any test to use in that intermediate score other than oncotype DX as such,
Right.
particularly for predicting the benefit of chemotherapy.
Right. Dr. Akhil?
If you exactly see into the subset analysis of the Taylor-X trial, so they have divided intermediate risk into 16 to 20 and 20 to 25.
Yes.
And if you see the risk of recurrence, it is only around 0.5 to 1% in that 16 to 20. And once it is around 20 and above, it is around 6.5 to 7%. So in this scoring, I would err towards chemo and would counsel the patient in that way. Yeah.
Right. So we move on to the next clinical scenario, Dr. Vaishali.
Yeah, thanks, Dr. Chirag. So this lady, now we are going to move to a node positive.
Can I add
Next slide, please.
Can I add a little bit on this?
Yes,
Yes,
please.
Dr. Sanjit.
So 16 to 20, the benefit is around 2.6%. And we don't know that this benefit is due to the ovarian suppression due to chemotherapy or it's real chemotherapy benefit. So what we are doing at present, we are discussing chemotherapy as a first hand, but if the patient is not very willing for chemotherapy, in this group of the patient, we are discussing ovarian suppression at least.
Right.
Yeah. So this is a young lady, premenopausal, an IT professional, very well read, tumor size of 3 centimeter, grade 3, ER/PR strong positive, HER2 negative, and a Ki67 of 30%. So she had 3 nodes positive. One of them was macro and 2 micromets. No extranodal extension. So that makes it T2N1A. So we now know that obviously this lady is going to be advised chemotherapy because she's premenopausal and node positive. However, she insists, as most of the patients who come to us insist that they do not want to, and they say ki doctor sab chemotherapy se bacha lo. So Dr. Aditi and Dr. Sanjit, what would you do? Would you counsel the patient yourself for chemo, or would you send the patient to the medical oncologist, or would you offer a recurrence score? Dr. Aditi and Dr. Sanjit, one by one you can take.
So I would counsel this patient in favor of chemotherapy, to be honest, to begin with. She's premenopausal, 3 node positive. I know, although we've talked about grade and Ki67 not correlating, but grade being 3 and Ki67 also being high. I would counsel her in favor of chemotherapy and refer her to a medical oncologist for further treatment. If the patient insists on, avoiding chemotherapy, I think still my line of recommendation would still be to go ahead for chemotherapy. I think the data for premenopausal, as we've seen, is not strong. So my recommendation would always be towards chemotherapy. If the patient insists and wants to go for a risk assessment tool like a multi-gene assay, can do it just on the basis of their choice.
Dr. Sanjit, do you agree to this?
Yeah, I completely agree. I will not do anything different what she said.
Right. So now we move to the medical oncologist. Obviously, the choice is very clear here. But if she insists, then if it is done, how do you counsel her, right? When we say that between 0 to 13, the benefit is say 2.3%. Beyond 14 to say 25, it is 2.7%. So what does this figure mean? If she says that, what is the meaning of this 2.3% or 2.7% benefit? How do you counsel? How do you interpret that? Dr. Venkat.
Neerav, can you change the slide, please? Next slide.
Yes, ma'am. So when we see the benefit For example, in score greater than 26, the absolute benefit is up to 24%, which means out of 100 patients receiving chemotherapy, 24 patients will have the benefit. So
Right.
there will be a set of patients who might not be actually benefiting from therapy, but it is the percentage of women who are actually going to get benefit if we administer chemotherapy so many of the patients. So number needed to treat a similar sort of. So this is how I discussed, and so for the individual patient, when we are discussing the risk, it may not the result may not be appropriate to discuss when we are for the single woman. So it is definitely
So obviously, we have to give her the fact that it is a statistical figure, may not be applicable for her
the
as an
individual.
individual. Correct. But if she still insists, and if the score comes out, say, between 0 to 13, would you still be happy to, let her be without chemotherapy? Dr. Akhil, would you want to take that?
No, I would, even if the score is less, I would still tell her that there is a risk and she would benefit if she takes. Yeah, even if the benefit is small, she has to take that risk, and I would counsel her in that way.
So
Yeah,
that
because if you
means,
see that she's
yeah,
42 years, so she's
42.
heading towards that. I mean, that perimenopausal period. I mean, close to 42. So this is that special age group between 40 to 45, where the chemo itself can drive her into a menopause state. So that is the best way to, get the benefit out of
That
chemo.
is how you counsel her, right? So if I have to modify the situation, and if I say that this is not invasive ductal, but if it is invasive lobular, will your advice change? Dr. Venkat?
So in the inclusion criteria, most of the things is invasive ductal carcinoma. So lobular, I think there is no data as such for lobular cancers because the behavior is different, and maybe they are excluded from the study. But I am not sure. Maybe Santosh Akhil can.
Yes, sir. So they have basically taken IDCs only, invasive ductal only. So they have included invasive lobular, they have included BRCA positive, bilateral cases, T3 also. T3 subset also was taken out of the Taylor study. So these groups were not there.
Elders haven't included grade 1 also. It's a grade 2 and a grade 3. So
yes.
if this woman, unless the score is less than 10, she is going to receive chemotherapy.
She is going to. And if the nodes were, say, micromets, all of them micromets, M1 MI, N1 MI, would you rather agree to doing recurrence score?
Definitely, because that is one of the subset where it is oncotype DX is approved, and N1 MI and N1 as well.
Right. And your threshold for advising recurrence score would change if she was a menopausal lady, postmenopausal lady? In this situation, if she was, say, 55 and post...
Taking the call for chemotherapy might change. If it is, unless the score is more than 26, I may not advise for chemotherapy. But in this woman, any score more than 10, she would go for chemotherapy.
Right. Absolutely. So her score, next slide, please, Mr. Nira. The next one. Yeah. So her score came out as, again, click one more time. So her score was 16. So in this situation, would you accept this score, or would you have expected a little different, or probably a higher score, or will you accept this?
That is what we have learned from the data, that clinically seeing a bigger tumor, clinically seeing a higher grade, higher case system may not actually correlate with oncotype DX. So if the score is 16, it is 16. So 16 to 20 and 20 to 25 are still benefited from chemotherapy to some extent. And considering the clinical risk as well, so this patient would be counseled for chemotherapy.
Right. So that answers my next question. So I'm going to skip that. And over to you, Dr. Chirag, for the next one.
Yes.
Next slide, please.
So, Dr. Sanjeet, do you counsel every eligible patient for recurrence score testing, or sometimes there is a situation where you actually don't counsel the patient who is eligible for a risk assessment?
So if they are eligible as per the trial data, so premenopausal node negative and postmenopausal both node negative and node positive, we generally counsel. But if ER is very low, if ER is 3 and 4, so these type of ER low, we generally are very reluctant to discuss genomic assay, because ER low generally behavior is towards ER negative disease than ER positive disease. So ER 4 and ER 5 HER2 negative. I don't know how much where this representation was there in the TAILOR-X or the RxPonder trial, but if the ER is very low, we are not discussing Oncotype DX with the patient or not counseling the patient in this.
Dr. Akhil, your thoughts? Dr. Akhil?
Exactly the same thing for premenopausal node, except for premenopausal node positive, I would be favoring. I mean, I would be counseling the patient for an Oncotype DX test. But again, the percentage of ER low positives were very low in the in both the landmark trials. So in those cases, I would be a bit skeptical.
And Dr. Alpi, who counsels the patient? So obviously, such patients are undergoing upfront surgery. So do you take on the lead to counsel the patient for Oncotype DX, or you leave it to your medical oncologist?
So actually, it's a very practical decision. Generally, I counsel, but if I know that there is some patient who is who are a borderline case, maybe a young patient with a grade 3 kind of a tumor or some clinically high risk features, or a node positive postmenopausal patient, then I tell them about that option, but I tell them to meet the medical oncologist as well to get their buy-in. But yes, I sensitize them. And if it's a classic, node negative postmenopausal case, then I would probably send the test also if the patient is willing.
And what would be the right time to counsel the patient regarding the test? So you generally wait for your histopathology report and then counsel the patient, or is it in between meetings when the patient is being taken up for surgery? And, there are patients who are anxious about, knowing everything about their treatment till the last on day one. So in such cases, what is the right time to counsel the patient, and how it is in your clinical practice?
Generally, when we are discussing the treatment plan before surgery, I would probably just drop in a word that this may come up once we get the histopath report, but the detailed discussion would happen with the histopathology report. Again, it depends if it's a classic, how much the patient is aware and how much they want to go into detail. But sometimes we do mention this in the preoperative counseling only. But the detailed discussion does happen with the final histopath report. So
Dr. Venkat?
Yeah. So to your question, Dr. Chirag, who should counsel the patient? I think the entire team. That's the reason why we are all discussing here. So be it with a surgeon, radiation oncologist, medical oncologist, because it's like, reinforcing each other's decision, and the patient will get more confidence. Particularly when we are doing such a costly test, it's important that that is the right decision. The patient will get the recommendation correctly. Second, what is the right time to counsel the patient? As you said, it is always better that if you get so-and-so report, you might need this test. Even before the surgery, if we can counsel, that would be the right time. So the patient would be prepared mentally. And if at all patient, particularly in India, if at all he has to ask the insurance company or in the finances, that would be there would be some amount of margin of time that you would get. So I think we need to advise that this test may come into play if at all in this particular report.
So, Dr. Minali, ma'am, how often have you been involved in, counseling patients for risk assessment scoring, and what is your clinical experience with that?
Dr. Jain, actually, I think I am not the right person to answer, but because, I am in KGMC, and I'm in KGMC is getting 100% of, so 99% I am the BPL patient. Okay, so I don't think I have faced this situation very often, but I remember once or twice in the last 5 years. And that time, yes, surgeon, me, and medical oncology, we all sit together and counsel the patient. It's not only like I have to counsel or my medical oncologist has to. It's all MDT type of discussion and counseling.
Yes, sir.
Can I make a comment?
Yes, sir.
Yes.
You see, these are the patients who have been primarily operated. And The day the biopsy report comes, patient wants to know from the surgeon everything. In fact, they even ask about side effects of chemotherapy, for how long, the cost. So two things. One, you and your medical oncologist has to be on the same platform. There should be no difference of opinion with your medical oncologist. So whether you counsel or your medical oncologist counsel, the counseling should be virtually the same. But definitely, these are primarily operated patients. Patient comes for the first dressing day. By that time, your report comes, and patient wants to know everything. Very few patients we do discuss before the surgery, because it creates a lot of confusion in the patient's mind, and anxiety increases. So most of the time, almost in 90%, I am discussing the patient oncotype on the first dressing day. When the biopsy report comes, I ask them, go home, read about it, give them 2-3 days, and when they come for the next dressing, I think that is the time when they take a decision. The report comes in 2 weeks. Your next treatment is going to start in 3 to 4 weeks. So I think there is no delay in the treatment by and large.
I think we, since we do frozen section for sentinel nodes, so and mostly the sentinel node frozen section result is concordant with the final in most of the situations. So usually, if the patient is reported as node negative on frozen, I sometimes take this opportunity to advise Oncotype DX at that time in some of the patients. So probably that might save a week or so. In taking the decision, final decision.
So, Dr. Venkat, are there times when you tailor your treatment based on oncotypes? Like whether to give chemotherapy or not, that could be a very clear situation. But are there times when you have to tailor it to there are cases where patient goes for just 4 cycles of chemotherapy, and what are those situations, and how do you counsel the patient regarding that?
So, Chirag, if I get the question right, are you asking that we have started chemotherapy and then awaiting the Oncotype DX report?
No, not that. I'm just asking, just in case the patient comes out to be intermediate score, a premenopausal lady. So, apprehensive about undergoing full chemotherapy. So, such patients, are they eligible for 4 cycles of chemotherapy, 4 cycles of TC or something like that?
No, then the data kick in was whether the patient, if it is the clinical risk group, this stratification. So if it is not very clinically high risk, maybe I would avoid anthracycline to avoid long-term cardiotoxicity, because there is data to support, even if we avoid anthracycline with the taxanes and cyclophosphamide, the efficacy will be almost equal. So if there are such concerns, then I would counsel for similar chemotherapy. So otherwise, I would like to give the full chemotherapy when eligible.
And while awaiting reports, because there are, not every center is well equipped to, give the histopathology report within 1 week or 10 days. And there can be a delay in the histopathology report, or, arranging the Oncotype DX test, or the patient deciding on it or not. So is there a case for starting endocrine therapy while awaiting the report, or you usually wait for the reports?
So that would be a case-to-case basis again, and that is not recommended as such to start endocrine therapy and then to halt it and go on for chemotherapy if at all indicated in the recurrence score. That is the reason why we need to plan everything at advance, in fact, before the surgery, so that everything happens in time. Once we cross 6 weeks time of adjuvant chemotherapy, we are not sure of the benefit of chemotherapy, or a doubtful benefit. So all these doubts will come, and we are good doctors, still patient have recurrence. So all this will be scrutinized very carefully. Why do you suggest this or that when the patient has recurrence? So I think it's better to go by data and timelines that are prescribed conventionally.
So 6 weeks is the cutoff that you consider from surgery to make a decision on whether to yes or no to receive chemotherapy. 6 weeks.
Most of the cases, yes.
I think it is imperative. Sorry, just a few treatments. It is imperative to embark on the importance of getting the test done timely, because many a times patients run from pillar to post. They seek many different opinions when it comes to a very borderline situation. So we have to emphasize that it is a time sensitive issue, and whatever decision they have to take should be taken sooner, so that the time lost is actually not much.
Yeah. In fact, if the patient is not getting oncotype DX, if there is a delay, and if there is a clinical high risk, we can always document that the patient is not willing or unable to get the test in time. In the bit
Right.
to start chemotherapy to avoid any medical legal complications.
Correct.
And just a hypothetical scenario, in case such a patient who has undergone a breast conservation surgery in such a scenario, like you said, the endocrine therapy, there is no data to start as such. Dr. Minali, have you ever been faced with a situation where, a RT was started for a patient who's undergone breast conservation surgery, not too keen on chemotherapy, awaiting a oncotype DX score?
I guess there is no doubt. I mean, there is no confusion or there is no harm to start patient for radiotherapy, because right now, whatever I am aware, there is no as such strong data where we have to take decision for radiotherapy on the basis of oncotype DX. है ना? Except I guess one paper that come last year, that is the idea paper, but that is also for the postmenopausal ladies and tumor size only up to 2 centimeters. So I don't think there is any confusion to start radiotherapy. And any role of this oncotype DX score to decide about the radiation for BCS patient.
I mean, to start while awaiting the oncotype DX result. In the meantime, in patient who is undergone a breast conservation surgery would definitely be requiring RT. So for such a patient, while awaiting the oncotype DX report, is there a situation where we can start RT?
Yes, definitely. No doubt.
Right.
But on the other side, Chirag, you are telling that 6 weeks is the appropriate period to start chemotherapy.
Exactly.
So chemotherapy will not be started within 6 weeks.
Exactly.
But I think I think if a patient cannot make a decision in 3 weeks time, he will never make a decision. And in 3 weeks time plus 2 weeks of reporting, I think 6 weeks. Rarely any patient it gets delayed for the treatment beyond 4 or 5 weeks. In my practice, at least.
So, yeah. Mostly patients do come with the results, and then we are able to sequence the treatment properly the way it should be.
Yeah.
But occasionally, I have had one such patient who came quite late, and then the oncotype DX was done quite later. Anyway, so next slide, please. So since we are running out of time, I'm just going to please give all the entire slide. Yeah. So known the guidelines, we know there is the validity of oncotype DX has been proved beyond doubt. Just a few questions about what about multifocal, multicentric, or bilateral hormone receptor positive tumors? Do we need to perform the test on all the tumors, and how does that go cost wise? Dr. Venkat, have you had such a situation?
No, ma'am. So, practically speaking, I had counseled only 10 patients for oncotype DX in the last 1 year, and only one patient underwent oncotype DX. So, coming to the multifocality of ER positive tumors, maybe I will send the most or the least positive ER to the oncotype DX, because in most of the situations in oncology, we'll treat the most aggressive cancer first. So, if there is a histopathology available for all the multifocal tumors, then I would set the least ER positive tumor for the oncotype scoring, so that I would get the most appropriate score.
Okay. Right. Dr. Santosh, do you agree with this?
Yes, bilateral ER positive tumors where conveniently they have not been taken in the Taylor X trial. Also the BRCA mutated patients. So I would obviously go for chemotherapy. So I would explain this to my patient and I would counsel them for chemo.
Okay, so but if both the tumors are low risk, node negative, and both bilaterally the patient has very low risk disease, then would you send the
still despite lack of data, I would still go for chemotherapy.
Go for chemotherapy. All right. Okay. Now, just a few word about the litigation, because one of the ladies who came to us, T2N0, the score was 17. She was put on tamoxifen, but she developed bone mets at 2 years. Have you faced any such situation, and was there any litigation issue? How do you handle such a situation?
Yeah, ma'am. So that was the discussion in the second case. So whenever there is an intermediate score, even if there is a moderate or mild benefit, we need to discuss, document it clearly that such a amount of maybe 2.3% or 3.2%. We need to clearly discuss that based upon this, the therapy has been discussed and patient has denied chemotherapy, agreeing for the close follow-up. And when such a documentation has been done, I think in most of the cases we are on the safe side. But if such a documentation had not been done and only test is done, then definitely, because the entire discussion which we might have spent for a few hours may not be reflected in that court. So yeah.
So if the situation is that if she is postmenopausal and the score is low, and still she develops, say, metastasis in very soon after starting the endocrine therapy, then do we, as a oncologist, do we have that onus to face the litigation? I mean, are we liable to face the litigation in such a situation?
So definitely, ma'am. So let us say it is greater than 26 and we have given chemotherapy and within 6 months patient can have recurrence. So even after giving chemotherapy. So having recurrence is not a liability of oncologist. And so for each and every patient, in fact, I do write because I practice in a very much periphery and the understanding of people is very less. So I do that till 5 years, the follow-up is needed and we declare cure only after 5 years if the patient has no recurrence. That is the document line I mentioned in each and every adjoint case.
Right. So you emphasize on the fact that the patient has to come for regular follow-up and appropriate testing has to be carried out, even if she's avoiding chemotherapy. Is that correct?
Yes, ma'am. Definitely. Because recurrence is not zero when we avoid chemotherapy in less than 26 and not zero even if we give chemotherapy after 26 score. So
right. So one last question from my side. We know that there are a variety of tests, mama print, PAM50, endopredict, breast cancer index, and all. So, but still we, tend to move towards only oncotype DX. So is there any particular reason? Dr. Akhil, would you want to take that?
Yeah, because I think Oncotype DX is the only test that is both prognostic and predictive of chemotherapy benefit. And if you see the trials like EndoPredict and PAM50, so they have not been prospectively validated in any studies. For MammaPrint, we have the MINDAC trial. And I think for regarding the breast cancer index and the molecular grade, that is basically for assessing whether any extended endocrine therapy is needed or not. And it is basically not for chemotherapy decision. So regarding all this, I would rate Oncotype DX higher above all the other available platforms.
Yeah. Dr. Chirag, any other question? Do we have any?
No, ma'am. I think we have answers to most of our questions on Oncotype DX. And it's been a great panel discussion. So thank you to all the panelists. And thank you, Vaishali ma'am, for helping me out with the panel. Over to you, Dr. Prakshi.
So thank you, everyone. That was a great discussion. Now I would like to invite Dr. Arun Goyal, sir, for giving vote of thanks.
Thank you, Dr. Prakshi. It's a privilege and an honor for me to be giving this vote of thanks. As was mentioned in the beginning that it is the 34th webinar of the series, and in addition to these webinars, we also had 2 conferences previously. So overall, what COVID started is something which I feel is very good. I personally enjoy these webinars very much, and it gives us an opportunity to really get people from all over the country on a single platform and from the comfort of our home.
So with that, I would like to thank all the faculty members, the speakers, the panelists, my organizing team. Definitely, as Dr. Rajiv always says, it's the younger people who are doing all the hard work, and we are just sort of just encouraging them. And I would like to thank all the audience here, and I must say it's the audience which encourages us to go on, because we have had a very enthusiastic response. So with that, I would like to say thanks once again, and we'll be back in a few weeks with the next episode. Thank you.
Thanks to Mice Ideas.
Thank you. Thank you so much.